Okay, special topic. Coronary artery trivia and related pathology. Um, some people talk about this circle and half loop model for understanding or describing the anatomy of the coronary arteries. Basically, the circle is the RCA and the circumflex, whereas the half loop is the LAD and the posterior descending. So you'll hear the word cardiac dominance thrown around. So what decides cardiac dominance? So cardiac dominance is basically whoever gives rise to the PDA, or crosses the crux of the heart, cross the posterior interventricular groove. Now, it's almost always the right coronary that's doing it, like, I don't know, 70% of the time, something, 80% of the time. But occasionally, like maybe 7 or 8% of the time, the circumflex will give it off. And again, it's whoever is crossing that interventricular groove posteriorly and giving off the PDA. So let's do some more anatomical trivia. So here's your RCA coming off the right cusp, and the first branch of the RCA is usually this coronary sinus artery, or conus artery in some people. Second branch, which is the one that's way more important to remember for the purpose of multiple choice, is the SA node. So if you're asked, because remember, SA, you're going to get heart blocks and stuff like that if the SA node is screwed up. So what blood supply for the SA node? RCA. It's usually the second branch. All right, let's do some more anatomic trivia. I've color-coded this. Blue is the left main, and then we're going to come across here, and you're going to notice that instead of having 2, there are 3 different branches of the left main. So normally it's LAD, right? Circumflex, right? But then we've got this guy here, sort of giving you the middle finger. You don't know who I am. Well, there. Now it's the middle finger. Well, giving you the index finger. This is LAD, circumflex, and this guy here is the ramus intermedius. So there is a normal variant that can occur where instead of having 2 vessels, there's 3, and the one in the middle is the ramus intermedius. All right, so more trivia. This is normal anatomy here. So which one of these guys here gives off which one of these guys here? Let's do some matching. So the LAD gives off the diagonals. D for diagonal. That's how I remember that. Circumflex for obtuse, and RCA for acute. Now, how do you keep that straight? How do you keep these 2 straight? So this D for diagonal. All right, what about these 2? How do we keep those straight? This is how I do it. Think about the R and RCA, and then I think about this right here, an acute angle, acute marginal. All right, and then the obtuse one is the other one's the other one. All right. Okay, so here's a diagram here. I'll sort of label it for you. This is your pulmonic valve and your right ventricular outflow, and then here's your right cusp, left cusp, non-coronary cusp. Now, why is it a non-coronary cusp? Because it doesn't have a coronary artery coming off of it normally. So right coronary artery coming off the right cusp, left coronary artery coming off the left cusp with the LAD and the circumflex. That's normal. So here are 4 variant anatomies, okay, using that same diagram, and all of them are demonstrating the left main coming off of the right cusp. So which one is the deadly one? Which one is the one you do not want? You're going to have one of these. It's also the most common. The this one. So this one is the intra-arterial here, and retro-aortic, makes sense, pre-pulmonic, and this one here, probably a lot of people would think that one's the worst, the subpulmonic, but it is not as bad as this one is here, which is between two high-pressure systems and supposedly can get pinched. So here's a real version of it. You can see should be coming off here, but instead it's coming off here, off the right cusp, right next to the normal. And you know, it's not just the left can do this, the right can do it too. So pay attention. But you know, this is actually the most common anomalous left coronary and right coronary. And it's associated with common or sudden cardiac death in up to 30% of patients, actually. So it's fairly common, like badness is fairly commonly associated with it. The other piece of trivia worth knowing is that the anomalous left off the right cusp, this one, they always repair that. This one here, the anomalous right off the left, they don't always repair it. They only repair it if it's symptomatic. So this one is worse than that. All right, so this is sort of a reformatted heart, and I'm going to be kind and label it for you. Left ventricular, left ventricle, left atrium. Here's the PA, and then we've got a vessel, coronary vessel, coming off of the PA. So what's that? So that is an anomalous left coronary artery off the pulmonary artery, or El Kappa. And when I say El Kappa, you will say Steele syndrome, okay? So Steele syndrome is basically a reversal of flow. The pulmonary artery has low pressure, a low resistance pathway, and that blood flow follows the path of least resistance, so you can have a sucking back into the pulmonary artery from that coronary artery, which obviously that's bad, right? That's going to cause ischemia, and that will cause death. So El Kappa, Steele syndrome. All right, next case, some reformatted hearts here, and I'm going to put an arrow on something, which is this guy. So notice that this coronary is covered with meat right here. So this is myocardial bridging, and it's basically you know, some muscle, band of muscle that's over top of the coronary. It's usually the middle of the LAD. Another thing that could be shown, which would be really a dirty trick, would be this cardiac cath appearance, which is a milking up and down or a stepping up and down that you can see as the muscle contracts. And you can imagine it's sort of pushing the blood flow back up and down. Another thing, trivia worth knowing, is that, you know, usually with a gated cardiac CT, you're going to sort of try to image in diastole, maximum dilation, or maximum vasodilation of the coronaries, and for the least amount of motion. However, if you suspect myocardial bridging, you should get systolic and diastolic phases to look for segmental luminal narrowing with systole, right? So diastoles, you know, when those coronaries are going to be the most open normally, but if it's getting smashed, you know, during systole, you're going to see that because of the myocardial bridging. So bottom line, cardiac CT, if you were protocoling cardiac CT and suspected myocardial bridging, you'll want to see both systolic and diastolic phases. All right, so we got an aneurysm of the sinus of Valsalva here. Which cusp is usually the one that it's aneurysmal? So I want you to remember this picture. This is the common one, okay? It is the right cusp, usually. And by usually, I mean like 70% of the time, something like that. The non-coronary is the second most common, and the least common is the left. All right, Next case. Family medicine wants you to biopsy that lymph node right there. So anytime you're asked to biopsy something, it used to be an old oral board trick to try to get you to biopsy stuff that wasn't a vessel or wasn't a soft tissue thing. Instead, it was a vessel. So that guy right there. So this could be a lymph node. Very well could be a lymph node, especially on this single image. There's no way to know that it's not a lymph node on a single image like this. But if I showed you a chest x-ray like that, you'd think, A, it's arterial. But what if I told you it's got a venous blood gas? Then what is it? So this is the persistent left-sided SVC. And the thing they always like to ask, most common trivia question that always seems associated with this is, where does it drain? So that was always the question that we used to get in case conference or at the view box. So where does it drain? It drains into the coronary sinus. Okay, so one more case here. Zoom in on the heart here. And what we're seeing is dilated coronary artery, aneurysmal coronary artery. So coronary artery aneurysms, at least in the western part of the world, are usually atherosclerotic in adults. In Japan, it's the Kawasaki's. But for the purpose of multiple choice, this is the way that I want you to think about it. In an adult, especially if they show you calcifications and athero and those kinds of things, call it athero. In a kid, call it Kawasaki's. And then if there's a history of recent cardiac cath, then think about pseudoaneurysms. That is a thing that can occur. All right, it's good for this.